Hello, everyone, and welcome to our module on COPD. COPD refers to chronic obstructive pulmonary disease, and it includes two subdisorders, one called chronic bronchitis, the other called emphysema. These two subdisorders of COPD have different pathophysiology, which we'll talk about in this video. And decades ago, they were thought to occur separately, but it's now recognized that they both almost always occur together. And so we call patients who have evidence of either one of these conditions patients with COPD. And COPD is a chronic lung condition. It leads to dyspnea, poor oxygenation, and poor ventilation, meaning decreased ability to blow off carbon dioxide. And it's strongly associated with smoking. The majority of patients who have COPD either currently smoke or previously smoked a significant amount. So COPD is the classic example of an obstructive lung disease, which I talk about in detail in the video on pulmonary function testing. But I just want to review the expected spirometry tests in a patient who has obstructive lung disease, including a patient with COPD. So in obstructive lung diseases, there is air trapping inside the lungs. There's slow flow of air out and less flow of air out. This means that the FEV1, the forced expiratory volume in 1 minute, goes down because of slow airflow out of the lungs from obstruction. There's also a reduced forced vital capacity because patients are able to blow out less air because of the obstruction to airflow. And then finally, the ratio of FEV1 to FVC falls in obstructive lung disease compared to normal. And this is the hallmark of all obstructive lung diseases and distinguishes them from the other form of chronic lung disease, which is restrictive lung disease. Now, all those lung volumes on the last slide, like FEV1 and FVC, those spirometry volumes, they go down in obstructive lung disease. But the other lung volumes, like the ones listed here, they go up. So residual volume, total lung capacity, functional residual capacity, all of these increase in obstructive lung diseases like COPD. And that's because air is trapped inside the lungs and can't get out. Therefore, you have a higher residual volume, a higher TLC, and a higher FRC. The opposite happens in restrictive diseases, which I talk about in another video. In those conditions, less air fills the lungs, and this leads to lower lung volumes like the ones listed here. So the four major obstructive lung diseases are all listed on this slide. The first two are chronic bronchitis and emphysema, which are both part of COPD that we're discussing in this video. The other two are asthma and bronchiectasis, which I talk about in another video. But you should be aware that a key differentiator among all these causes of obstructive lung disease is the response to bronchodilators on spirometry. So if a patient has a spirometry test and you find evidence of obstruction, you can administer bronchodilators and then look for changes in the FEV1 and the FVC. If there's complete improvement of the FEV1 and FVC all the way back to normal, that's what you expect to see in asthma. In contrast, in COPD, what you get is either a partial improvement or no improvement at all. Okay, so now we're going to talk about the two elements of COPD, each one at a time, and we'll start with chronic bronchitis. So chronic bronchitis is a lung disorder that's diagnosed clinically. In order for patients to meet the definition of chronic bronchitis, they have to have a chronic cough that's productive of sputum for at least 3 months over the last 2 years, and they have to have no other cause of cough present. And lastly, this is strongly associated with smoking, so most commonly this diagnosis is made among patients who smoke. So what's going on inside the airways in chronic bronchitis is that the constant exposure of the airways to irritants like cigarette smoke leads to hypertrophy of mucus-secreting glands, and it's high yield to understand this and to have this picture in your mind of chronic bronchitis. So if you look at this cartoon on the side here, this is what a normal airway might look like, and this is what one might look like in a patient with chronic bronchitis. First of all, you can see there's lots of mucus. You can also see that the walls are thicker, and the reason they're thicker is because of hypertrophy of mucus-secreting glands. In fact, when patients die of chronic bronchitis post-mortem, you can determine something known as the Reed index. This is the ratio of the thickness of the submucosal gland layer to the total thickness of the airway wall. So the total thickness is everything from the epithelial lining, the airways, all the way to the cartilage. And so that's the denominator here. And then you measure the thickness of the submucosal gland layer, and that's how you determine the Reed index. Less than 0.4 is normal, and in patients who have chronic bronchitis, it gets much higher than 0.4. And so what all this means in terms of the patient is not only is there obstruction to getting air out of the lungs, like we talked about earlier, but there can also be mucus plugging from all this excessive mucus here. And with all the mucus around, that can become an area for bacteria to fester. And so there's an increased risk of infection when patients have chronic bronchitis. Another pathologic change that you can see post-mortem in patients who die from chronic bronchitis is metaplasia of the bronchiolar epithelium. So this is what the bronchiolar epithelium should look like. The epithelium lining the airways in the bronchioles should be pseudostratified ciliated columnar epithelium. But what happens when you chronically expose the bronchioles to irritants like cigarette smoke is they undergo metaplasia and they convert to become stratified squamous epithelium that looks like what you see in this picture right here. Another thing that can happen in chronic bronchitis is shunting. I talk about shunting in a lot of detail in the video on hypoxemia, but just to review it here, let's imagine that you have air coming into the lungs here, and some of it goes over here to this healthy alveolus, but some of it goes over here towards this alveolus, and it can't get in because there's a mucus plug right here obstructing the flow of air into the alveolus. Well, what's going to happen is capillary blood is going to enter this pulmonary capillary, and because this alveolus is healthy, it will become fully oxygenated to 99% saturated hemoglobin. On this side, however, blood is going to flow in and it's not going to get oxygenated, so it's going to leave the capillary with less than 99% saturation, in other words, lower than normal hemoglobin saturation. And then the blood streams will mix, and what you'll get is a patient who has hypoxemia from shunting. Importantly, if you give oxygen to this patient, it won't help because you'll be adding oxygen only to the healthy alveolus, and it's already doing all it can in fully oxygenating hemoglobin. None of that oxygen will get to the unhealthy alveolus, and so this will continue to be under-oxygenated over here on this side, and that's shunting, which you can see in chronic bronchitis. So in this slide are some of the items that you see in terms of overarching pathophysiology in chronic bronchitis. So first of all, there's poor ventilation of the lungs. This means that the carbon dioxide level can rise, and we'll talk more about this later. You can also have hypoxemia, meaning a decreased arterial concentration of oxygen. Whenever there's underventilation of portions of the lung vessels will undergo hypoxic vasoconstriction. I talk about this in other videos. That can raise the pulmonary vascular resistance, and that can lead to pulmonary hypertension secondary to lung disease. And if you have long-standing pulmonary hypertension, that can eventually lead to right heart failure, which is called cor pulmonale. So on this slide are some of the clinical findings you can see due to chronic bronchitis. Obviously, there can be dyspnea because of obstruction and shunting. Patients can have wheezing from narrowing of the bronchioles because of those thickened walls. There can be crackles from the mucus. You can also see cyanosis. This is from shunting like we talked about. The mucus can cause coughing. And then lastly, in any person who has chronic hypoxemia, including those with chronic bronchitis, you can see secondary polycythemia, meaning an increase in the red blood cell count and the hemoglobin and all the red blood cell indices. This is a response of the bone marrow to chronic hypoxemia. It occurs in COPD. It also occurs in many, many other chronic lung conditions. Okay, so that's chronic bronchitis, which is one part of COPD. The other piece is emphysema, and it has a different pathophysiology. So the pathophys of emphysema involves destruction of alveolar walls. So irritants like cigarette smoke activate macrophages, they recruit neutrophils, and neutrophils release proteases, which break down proteins and therefore break down the alveolar walls. When the walls break down, you lose the elastic recoil, and it's very important that you understand this. So the elastic recoil, which normally causes the alveoli to spring back, is lost. They basically become very, very floppy. What this means is when the patient inhales, they will overinflate the lungs, but then when the patient exhales, the small airways will collapse because they do not have their normal amount of elastic recoil. This is going to lead to air being trapped inside the lungs. And importantly, this will cause obstruction, but what can be confusing to understand as a student is it's a physiologic obstruction. So it's not like chronic bronchitis where there are thickened airway walls and mucus causing obstruction. In this case, it's a physiologic obstruction. It's because the airways are collapsing on exhalation because they don't have the normal amount of elastic recoil. Now, to understand emphysema, you have to appreciate that inside our lungs, there's always a little bit of inflammatory cell activity to pick up debris from the air we breathe. So there's always some proteases being released by inflammatory cells in our lungs, even in patients who have healthy lungs. But those proteases are balanced by antiproteases found within the lungs. And so what happens in emphysema is you get an imbalance where you have too much activity of the proteases and not enough activity of the antiproteases. So in patients who smoke cigarettes, there are too many proteases created. This overwhelms the antiproteases, and this leads to damage in the lungs. And usually this type of lung damage from excessive proteases is predominantly in the upper lobes for reasons that aren't entirely clear. In another rare genetic condition that we'll talk about later, patients have a deficiency of the enzyme alpha-antitrypsin. This is an antiprotease. And so when they're born with a deficiency, they have ineffective antiproteases, and that leads to this same imbalance here, where there's too much protease activity and breakdown of alveolar walls. In contrast, however, this usually leads to lower lung damage. Later in this video, I'm going to talk about alpha-1 antitrypsin deficiency, but I just want you to understand this underlying balance between antiproteases and proteases. So what are the clinical findings of emphysema? Well, the word emphysema is derived from a word that means swelling. And so if you know that, it's an easy way to remember that the lungs basically overinflate or swell. So patients with emphysema can have a barrel chest from air trapping. Their lungs can be hyperinflated from air trapping. This is a picture of an x-ray from someone with emphysema. It's hard to appreciate this if you're not used to looking at normal x-rays, but these lungs are much larger and hyperinflated compared to normal. You can also see over here that the patient has a barrel chest from all that air trapping inside the lungs. You can also see a fall in the DLCO from damage to alveolar capillaries. I talk about what the DLCO test is in another video, but it's a test that measures the ability of the lungs to exchange gas. And there's a decrease in the results of this test because you're losing alveolar capillaries, which obviously you need to exchange gas. And then because you're losing alveolar capillaries, that means there are less vessels for blood to flow through in the lungs, and that can increase the pulmonary vascular resistance. And this in turn can lead to pulmonary hypertension and cor pulmonale, which is a potential adverse outcome of all forms of chronic lung disease, including COPD. Let's talk briefly about the acinus, which is a term used in pulmonary anatomy and pulmonary physiology. So the acinus refers to structures that are distal to the terminal bronchiole. So let's look at this picture here, which I go over in the video on pulmonary anatomy. So we have a lobular bronchiole bringing air in, and then we get to these terminal bronchioles here. And distal to the terminal bronchioles, you find respiratory bronchioles, alveolar ducts, and the alveoli. And so these things collectively are called the acinus. In emphysema, what you get is centroacinar or centrolobular damage. This means dilation or destruction of the respiratory bronchioles. Usually the distal alveoli are spared. And the thought here is that most likely these irritants like cigarette smoke cannot reach the distal alveoli as much as they reach the proximal structures, and that's why you get this centroacinar damage. And as I said before, in emphysema, you see the most predominant damage in the upper lobes. In contrast, in alpha-1 antitrypsin deficiency, which we already mentioned and we're going to talk about later, you see pan-acinar damage. You see destruction of all parts of the acinus, and this often affects mostly the lower lobes. And the reason you can get problems in all parts of the acinus is because this is a genetic condition and the alpha-1 antitrypsin deficiency is present in all parts of the acinus. Here are some images of patients who have emphysema. So right here you can see this histopathology slide of the airways, and the basic finding here is that these airways are just much larger than normal and the walls are much thinner. Not easy to recognize this right off the bat unless you're used to looking at biopsy slides of the lungs, but you should just be familiar with the fact that the airways get bigger and the walls get thinner. Right here is a gross pathology image from a person who had emphysema. You can see all the black damage here, and it's mostly in the upper lobe of the lung as you'd expect. And then over here is just another chest x-ray showing hyperinflation of the airways. I don't think these things are easy to recognize straight away as a medical student. They probably won't show you these type of images unless they also give you a lot of clues in the question stem. So be familiar with them, but you don't necessarily need to be able to recognize them without any other context or clues. In the videos on pulmonary physiology, I talk about chest volumes and pressure, and I go over this graph shown on the slide in detail. It shows the volume pressure relationship of the chest wall here in red, the volume pressure relationship of the lungs here in blue, and then this green is the volume pressure relationship of the entire respiratory system, which is a mixture of effects coming from the chest wall and from the lungs. Well, what I want to point out to you is that what happens in emphysema is that the elastic recoil is lost, as we've already discussed. That changes the lung curve so it looks like this, okay? In other words, it shifts it up and makes it higher. That's going to move this FRC point here up and even higher. So I just want you to understand graphically what I already told you before in words, which is that the FRC goes up in emphysema, and that's because of the loss of elastic recoil. And what it does is shift this curve for the lung upward like this. So as I told you, we don't really think of chronic bronchitis and emphysema as separate clinical conditions any longer. We call them both COPD because almost all patients who have evidence of one of those conditions also have evidence of the other. But there's an old clinical classification from the times before when we used to think of chronic bronchitis and emphysema as separate disorders. And that classification was classifying patients as whether they were blue bloaters or pink puffers. This isn't really important in modern medicine, but I'm telling it to you just because it can help you keep straight the clinical features of the two conditions in your mind. So patients with chronic bronchitis were often called blue bloaters. They were cyanotic from shunting, like we talked about before, and this leads to cor pulmonale, and this leads to edema in the lower extremities, and therefore they were bloated. So that's why these patients were called blue bloaters. In contrast, patients with pure emphysema were called pink puffers. So they've lost their alveoli, which means they've lost surface area for oxygen absorption and carbon dioxide expulsion from the body. So what they would do is they would hyperventilate to compensate. This made them look like they were puffing all the time. And this would maintain their oxygen level so they were pink in contrast to the blue bloaters. So if this helps you, you can use it to remember the separate features of chronic bronchitis and emphysema. If this confuses you, don't worry about it because this is really an old system that we don't use anymore. So that brings me back to COPD, which, as I said before, is a catch-all term that includes the clinical features of chronic bronchitis and emphysema. These things almost always occur together because they're strongly associated with smoking, and rarely do patients only have one of these conditions without having at least some of the other. So in COPD, you have airflow limitation from obstruction. It's not fully reversible like asthma, and it's strongly associated with smoking. And you should know clinically that these patients often have intermittent exacerbations where their respiratory distress at baseline gets worse. This is often due to either a viral or a bacterial infection. You will see many of these patients treated in the hospital. They have to be treated with bronchodilators plus steroids to tamp down the inflammation and often antibiotics to treat the bacterial infection. So these patients will have stable dyspnea over a period of time, and it intermittently gets worse and sometimes requires increased treatment like what's shown here. On your board exams, it's unlikely they will simply tell you a patient has COPD. Instead, they will want you to recognize that the patient has COPD based on the clinical findings. So let's go over what the physical exam findings are in COPD. So first of all, you should know that the findings are variable based on disease severity. So in clinical practice, you can see patients with COPD who may have none or very few of these features on the slide here. But what's shown here are all the things you can see in patients with advanced disease. So pretty much all patients with COPD have dyspnea, but beyond that, you can identify these physical findings on exam in patients with severe COPD. So first of all, increased resonance to percussion. This is caused by hyperinflation. I talk about this in the video on pulmonary lung exam. You can also see decreased breath sounds, and that's also because of hyperinflation and less air moving in and out of the lungs. You can get wheezes from airway narrowing. The mucus in the lungs can cause rhonchi and crackles. Patients with any form of obstructive lung disease, including COPD, can have a prolonged expiratory phase. So if you watch them breathe normally, you will see that they take in a breath and then it takes them longer than usual to exhale that air. This is all from the airway obstruction. Sometimes this will be described as an increase in the I to E ratio. The I to E ratio is the ratio of time it takes to inhale versus exhale. And these patients have a prolonged expiratory phase, meaning the I to E ratio goes up. You can hear distant heart sounds when you examine the heart in patients with COPD. That's because of hyperinflation. And then if they have pulmonary hypertension and this has progressed to right heart failure, meaning cor pulmonale, you can see findings of right heart failure. So things like elevated JVP and lower extremity edema. And especially in a board question, when students see these things, they'll often think it's a primary heart problem. But if you see evidence of all these other things here, you have to consider that it could be a secondary heart problem due to chronic lung disease. Let's talk about the acid-base changes in COPD because these are super high yield to understand for your board exams. So remember that patients with COPD have loss of alveoli, so they've lost surface area for gas exchange. This means that it's harder to blow off CO2. Now initially they can try to increase their ventilatory rate. They can either breathe faster or deeper, but there's only so much of this they can do as the disease progresses. So patients with advanced COPD simply cannot ventilate enough to remove all the carbon dioxide from their blood. So they will have chronic hypoventilation. And this is going to lead to chronic retention of carbon dioxide. It's super high yield to understand this. And this will lead to a chronic respiratory acidosis. So these are the findings down here that you expect in someone who has long-standing significant COPD. Their PaCO2 will be up. When that goes up, that creates acid, so their pH will be down. And then in response, the kidneys will produce more bicarb. This is a chronic condition, so the kidneys have time to respond to the acid-base disturbance, and they produce more bicarb. So patients with long-standing COPD will have an elevated bicarbonate level when you measure their serum electrolytes compared to normal. And this is all part of the kidney's response to chronic acidosis. So everything I've listed here is super high yield to understand. I talk about this in the acid-base videos in renal, but I just wanted to review them here for you now. Okay, I'll finish this video by talking about alpha-1 antitrypsin deficiency, which you can think of as a variant of COPD, but it's not caused by cigarette smoking. It's caused by an inherited enzyme deficiency. So this is an inherited condition, and it's passed down through families in an unusual way, in an autosomal codominant manner. I talk about this in detail in videos in the genetics section, but in this condition, you inherit one allele from the mother and one from the father, and it's the function of the two alleles together that determines the disease severity. That's why it's called codominant. So this leads to either decreased or dysfunctional alpha-1 antitrypsin enzyme activity. And as we talked about earlier, alpha-1 antitrypsin balances naturally occurring proteases, including elastase, which is found in neutrophils and alveolar macrophages. So if you don't have enough of this enzyme around, you will have overactivity of proteases like elastase, and that will lead to breakdown of alveolar walls, somewhat similar to what you get in emphysema. So in terms of lung involvement, what you see in alpha-1 antitrypsin deficiency is pan-acinar emphysema, like we talked about earlier. The emphysema involves the entire acinus, not just the central portion like you see in traditional smoking emphysema. And it's caused by an imbalance between proteases like elastase and the alpha-1 antitrypsin inhibitor. This predominantly leads to lower lung damage, as we already discussed, and this is sometimes called a loss of function of the alpha-1 antitrypsin protein because this protein is normally supposed to oppose the proteases, but you lose that function in this condition. You can also see liver involvement in patients who have alpha-1 antitrypsin deficiency, and this is sometimes called a gain of function problem because it has a different mechanism from the lung problems. So this only happens in phenotypes of the disorder where pathologic polymers of alpha-1 antitrypsin can form in the liver. When this happens, abnormal alpha-1 clumps basically build up in the liver. Specifically, they aggregate in the endoplasmic reticulum of liver cells, and this is the kind of thing they'd like you to know for your step 1 exam. And you can actually see this on pathology. So if you look at liver tissue under the microscope, you can see inclusions inside the hepatocytes that stain for the PAS reagent. This is a picture of what they look like on the slide here. All these dark spots here are clumped up alpha-1 that's built up inside the endoplasmic reticulum of liver cells. Over time, this can lead to cirrhosis, but remember, this only happens in certain phenotypes, so it is possible for patients to have alpha-1 antitrypsin deficiency without liver involvement. And once again, this is called a gain of function problem because the alpha-1 antitrypsin protein is doing something it shouldn't, meaning it's building up in the liver, in contrast to the lungs, where the alpha-1 antitrypsin protein is failing to do its job. That's a loss of function. So the classic case of this rare disorder to know for your boards is a patient who has typical COPD symptoms like cough, sputum, and wheeze. Usually they will be younger. So for example, patients with this condition often present in their 40s, whereas people who smoke and develop COPD usually present in their 60s or 70s. On imaging, you can see emphysematous changes, but they're going to mostly be at the bases in contrast to traditional emphysema, which is more at the top of the lungs. The pulmonary function testing will show obstruction. And a lot of times the questions are going to ask you about the differences between this problem and traditional emphysema. So the question often asks about pan-acinar involvement versus centrilobular involvement. And then lastly, one thing to know is that these patients should never smoke. So they are born basically with an imbalance between proteases and antiproteases. And so if they smoke, they're going to have neutrophils recruited to the lungs to make more elastase, and that's obviously very, very bad. And that concludes our module on COPD.